Hello, I'm Arden Tomison.
My name is Ross Tomison.
We are the founders of Thalamos, and we're here today to talk a little bit about our work in digitising the Mental Health Act. First and foremost, big thank you very much to Becky Inkster for having us along today. Before we get going, very quick introduction to us. We started Thalamos in 2018. We did so after a couple of our friends were detained under the Mental Health Act. Previously, we had some experience of acute mental health there. My dad, Ross's uncle, is a psychiatrist. So we've had some experience into this world, but it was when two of our friends were detained under the Mental Health Act that we decided to start Thalamos. We did so specifically with the purpose of supporting clinicians to improve outcomes in the assessment and treatment of mental ill health. And we do that by creating digital enablers. We're a for-profit social enterprise. Which means that we are legally committed to a set of values, one of which is to invest 5% of our profits into research into mental illness. Neither Ross nor I are clinicians, and so one of the first things we did was to create a steering group of those involved with the Mental Health Act, different stakeholders with different perspectives. And they help provide us with that perspective and guide us on all the different things that we have to consider when working to digitise the Mental Health Act. A few of our other partners, we work with Mindway from a technology perspective, fantastic research charity called MQ Mental Health, and we're also part of Digital Health London, an NHS Innovation Accelerator.
And just a little bit around our ethical disclaimer. Thalamos is, in its current form, a digital tool for transferring legal paperwork between doctors, AMPs, nurses, MHA legal teams, and everyone else involved in care. In its current form, it is not a core record system, and we do not use the patient data entered into the forms for any reason. And this is reflected in our data so far, as it is based around the things that we can measure, such as the time taken to action forms.
So a little bit of background as to why we still use paper within the Mental Health Act. Admission to hospital under the Mental Health Act is a crisis care pathway. So it's an emergency care pathway, but it's one of the most complicated ones that you will come across. It may involve up to 10 individuals from 5 or 6 different institutions who are all expected to communicate and interoperate around a patient and their nearest relative. Interoperability is generally the buzzword of technologists, and it is something which certainly should be an aspiration. But we have to understand what that means within a real world scenario. So that is the ability of a social worker and a doctor who may work for entirely different institutions be able to communicate quickly and efficiently around a patient and their nearest relative and make sure that that person can receive access to care. And the Mental Health Act itself is from 1983, so it's no real surprise that the Act wasn't written with technology in mind. For those of you who remember 1983, that was the technology that was available then. That is an Apple computer, and that was the Motorola's first mobile phone of that era. And so one of the reasons we still use paper is because the Act was written in 1983, but the other is because it is actually an interoperable system with a relatively low barrier to entry. Assuming that one can read and write in English, then it is fairly simple to pass a paper form from one person to another. And it's that level of simplicity that we've been trying to replicate when digitising the Mental Health Act. Many people wonder whether that is a worthwhile endeavour if you do have an interoperable system that works. And so one of the first things that we did was set about trying to understand whether there were problems with the paper process and what those problems were. Were they tangible, and was there data around this? All of this was happening in a pre-COVID environment. As I said, Ross and I started Thalamos in 2018. And what we discovered is that yes, there are problems with paper. The plus points are that it's interoperable. The downsides are it's very prone to human error. It is prone to being lost. It is prone to being damaged. And we conducted a piece of freedom of information research on unlawful detentions and errors in admission paperwork between 2016 and 2019, we approached all NHS trusts, mental health trusts in England, and this is what we found, that there was a minimum of 1,034 unlawful detentions through that period. About 1/3 of the trusts that we surveyed were recording this data, and so it's a reasonably safe assumption to suggest that this problem is of a magnitude 3 times as great as this. So quite clearly there were problems with the existing paper process, and that's one of the things that we were trying to address.
So the problems presented by COVID were much the same as we knew existed before, but remote working measures have highlighted just how big these issues are. So mainly around the physical nature of paper means it has to be dealt with by hand. Someone has to scan it once it makes it to the hospital, and it has to get there by being physically passed between people in the majority of situations. Also, that the hardware within teams is lacking. There's been a big switch to video assessments, and if you don't have decent technology, it's not that easy to do those. So in terms of COVID-related change, we have had a lot of clarity around certain things. So before COVID, we were seeing very similar conversations around things like electronic signatures and their validity in terms of the Mental Health Act. It's traditionally been very unclear, but the Department of Health has issued very clear guidance on their usage during COVID. It's also shown the necessity that we do need a digital system. If healthcare providers want to go fully paperless, then the MHA forms themselves will need to be digitised. And around accessibility as well, there's been a massive digital upskilling across healthcare providers with increased usage of remote video calls between colleagues. So there's been a change of perception about what digital might be able to deliver.
So we think we've always thought the opportunity with digitisation has been to make things swifter, simpler and safer. And we think particularly in a COVID landscape or a post-COVID landscape, that opportunity is even greater. And that's why these are the things that we measure. So when Ross talks about what do we measure, we are looking for our metrics to be around these things. Is it swifter than the status quo? Is it simpler than the status quo? And obviously, is it safer than the status quo? This is a healthcare environment. You cannot do anything that makes something less safe. But often we do things that make something more safe, but at the same time, they can make that slower and more complicated. And when you're talking about a crisis care pathway, particularly one that's already complicated, we don't want to be doing that. So the data that we have got has been based around these 3 metrics. And one of the first things that we were doing when COVID arrived was we were working with the CQC to support their second opinion doctors moving to remote working. So our richest data set is from that population of people. And what we've identified is that by working digitally, they have been able to make access to treatment 5 times faster than it was before. Pre-COVID, the average time from a second opinion assessment to the patient receiving treatment was over 7 days. It's now 37 hours. 83% of forms are being actioned within 48 hours and 32% of forms are being actioned within 2 hours, sometimes in minutes. So really what we're seeing is a massive step change in the speed at which patients are able to access care. We're also seeing some things that might seem obvious, but that really do make a difference day to day. So the most frequent piece of feedback we get from Mental Health Act administrators, so from those working in the teams, is they can read the forms. And that seems obvious, and it doesn't seem like necessarily the most impactful care improvement. But there are lots of people whose significant proportion of their day has been trying to decipher doctors' handwriting. And now they're able to just do their job rather than be a decoder. when speaking with doctors, obviously we polled everybody who was using the software. 75% of doctors polled felt that digital forms represented a care quality improvement. Of the remaining 25%, there was a split between those who didn't feel it represented a care quality improvement and those who were just unsure and wanted to see more data. So our conclusions at the moment are that we think it is possible to start to realize data where there previously wasn't any. And that's important within the Mental Health Act. There is lots of anecdotal evidence of an overrepresentation of Black and minority ethnic communities being detained under the Mental Health Act, and yet there's very little data as to where and why that is happening. There's also lots of anecdotal evidence about patients feeling that they are not included in their care. But again, there's very little real data because most of that information is held on paper forms in filing cabinets up and down the country. So there's lots of opportunities for data, but in order to realize that data and in order to realize a digital act, it's becoming clear that healthcare providers need to start to embrace cloud computing much more than they necessarily realize they are. And I think what's been very interesting about the COVID period and very positive indeed is the speed at which people have adopted Microsoft Teams. The challenges, though, have been around the hardware, particularly in social care. So we have a situation where you have an NHS provider who is now reasonably digitally enabled, able to work remotely, and yet in many areas we have social care providers who are not equipped with smartphones or tablets or any device that will work with the internet in the community. So there are these individual blockers around the place. And what's been really fascinating to see across the Mental Health Act administration and legal teams that we work with is that 4 months ago, you had a population of people who were quite nervous of technology. They've been running pretty stable processes for 20 odd years of their careers and were nervous of new technology. And yet now they're fully conversant in video calling. You turn up to a video meeting and everybody's can set their own backgrounds. They know how to share and use the chat function, everything else. So we have massively upskilled the workforce, and that provides a huge opportunity for further digitization and getting and extracting this data. But there's still a long way to go. There are still those who are nervous. There are still those that need support and training. And certainly from our perspective, we think that's where there should be a focus if we're going to really realize the benefits of digitization. So thank you very much for having us along. Like I said, if you're interested in further information or more data, there will be more data coming out as we work with more and more trusts. Please don't hesitate to get in touch.